what's up, everyone? Welcome back again to Basically EMS, the EMS podcast for EMT students and EMTs. Got my man Wade over here, Paramedic Wade. I am Paramedic Chris. We don't say that enough so people know that we're paramedics.
Yeah. Could just be guys on the internet for all they know.
That's true. We still kind of are.
Yeah.
We just have, things after our name.
That's fair.
So maybe recap real quick. I'm Chris. I'm a paramedic for 10 years, EMS for 15 years.
I'm Wade. I'm a paramedic for going on 6 years. And yeah, I've been EMS for around the same amount of time.
Like 7, maybe?
Yeah.
Cool. Today, we are going to talk about strokes. So strokes is a pretty simple thing, but it's a very common thing that we'll see. And I feel like there's some deficiencies in some stroke mimics being taught at the basic level or some, you can delve into it a little bit more. And I think we're going to try to do that a little bit to go a little deeper than I feel like I was taught in my EMT class, and probably the same for you. So you're EMT instructor.
Yeah. Whatever you know, I know. So
yeah, that's fair. People probably wouldn't know this, but I was your EMT teacher back a long time ago. So
back in the day.
Back in the day. Somehow I tricked you into coming in here and talking to me.
I just kind of follow you around is what I've concluded.
All right. So strokes, right? Strokes are fifth leading cause of death and disability in the U.S. So it's a pretty high prevalence of deaths caused by strokes. I don't feel like I've seen a lot of code patients that were like very obviously strokes, but I feel like I've been on a ton of stroke patients in general. So
yeah, I mean, this was like a 1 to 2 a week type call.
Yeah, it's there's a whole heap of strokes that we'll see that aren't deadly but can be detrimental to patients for the rest of their life. And so we want to be able to try to recognize and manage that to hopefully get them back to a more normal life.
I mean, that's all we can do is recognition, right? Like we can't, nothing we do will save them, but we can get them to the right people who will.
Yeah, and that's at the paramedic level as well as the basic level. Generally, I guess maybe some progressive systems will have
like the mobile stroke units.
Yeah, they can do some clot busting medications or something.
Right.
But typically, not much we can do.
Right. And even outside of our state, it's not even a paramedic requirement call. A lot of it's like advanced EMT.
Yeah, because there's not a lot to do. Start an IV and go to the hospital real fast.
Yeah. Check a sugar.
Yeah. We'll get to that. Don't worry. So talking about the anatomy physiology, the anatomy can be very complex if we want to get into it. I don't think we need to at this level, but it's just the anatomy of the brain, essentially, right? So the brain has 3 major parts. We have the brain stem, the cerebellum, and the cerebrum. And the cerebrum is going to be that biggest part, right? So that has the right and left hemispheres. That's going to control emotion, thought, depending on where we're at, right? The front's going to be motion, thought, middle is sensation and movement, and then the back is going to process sight.
Right.
And it's important to remember that the right side controls the left side controls the right, but pretty straightforward.
That also does a good job of outlining, like, different lobes of the brain have different jobs. And so we'll talk about it in a bit, but like with where you see the stroke or where the stroke's occurring is going to dictate what we're seeing and being able to put that together. Yeah,
what part of the brain is affected will show different signs and symptoms, which is one of the ones specifically we talked about beforehand that we need to be talking about.
Yeah.
And that's the cerebellum, which is going to control muscle and body coordination.
Correct.
So type of strokes we don't talk about very often. And then there's the brain stem as well that's going to do like basic life functions. So breathing, blood pressure control, those kind of things. That's all managed in the brain stem.
The medulla oblongata.
Medulla oblongata. Little Adam Sandler.
Oh, yeah. Oh, yeah.
I know. You're old enough to get it. Maybe people watching this aren't. It's pretty straightforward, right? We have a whole lot of paper for not a whole lot to say about the anatomy, physiology level that we need to understand for strokes. Just there's a different lobes, different parts of the brain.
Right.
If it's affected differently, will present differently, and we need to be ready for that.
And if we think about even like we didn't talk about it, but meningeal layers around that, that plays a role. But then that's when we start entering like head bleed, which can have a similar presentation, but it differs.
Yeah. For the context of this, we're not really talking about head, and it can be kind of a mimic, but it's not really a stroke, right? Head bleeds are not really a stroke. But yeah, it can definitely look like a stroke. They can definitely mimic each other. So that's anatomy, really easy. And then coming down into strokes themselves, there's 2 major types of strokes we're going to be looking at, right? So Ischemic strokes are going to be like brain attacks.
Right.
So if you're listening to this, you understand the concept of a heart attack, which is a blood clot or some sort of embolus floating freely, gets caught in the circulation to that portion of the brain. It's going to block the flow beyond it, right? For all the blood clot stuff, I always try to think of a tree. And so I remember the tree has a big trunk, and then the trunk goes down into a large branch. Large branches go down into smaller branches, and then we get to the leaves, which are like the capillary beds, right? And so if we have a embolism or a blood clot that's stuck in one of the large branches, everything from that clot downstream is no longer going to be perfused. So when we're talking about ischemic strokes, depending on where that blood clot is lodged and how large that blood clot is going to make a difference as far as that presentation and what deficits we're going to see.
Right.
But yeah, so ischemic strokes, about 87% of all strokes. So this is much more prevalent, and this is typically much more of a disability as opposed to death kind of thing, right? Most of the time.
And a lot of this one has like the big precursors, like the uncontrollable factors of your gender, your age, even some of your health, some of it, but then also the factors, like you have your high cholesterol, your high blood pressure, like a lot of contributing things that we don't take care of ourselves for that just increase the rate, increase the risk.
Yeah, the atherosclerosis, the buildup of plaque can be a big contributing factor for this, because those arteries being narrowed means less blood passage through, means more of a catch for clots and emboli and all that stuff.
More stasis in the blood, static blood, clots, coagulates.
Yeah, exactly. So for those reasons, this will typically be elderly patients that we're going to see these in. Not always. I mean, there's teenage kids having strokes sometimes.
Yeah, I've heard of even babies in utero having strokes.
Yeah, it can happen, but which, we should take whatever the patient gives us, regardless of their age, sex, whatever, right? Like whatever the patient's presenting with, we need to jump into that. And I feel like EMS in general, we're much better about understanding that, right? Like I feel like even when I started, it was like, women don't have heart attacks. You know what I mean? And it was like, woo, or maybe we just missed them all.
Yeah. The ones who did aren't here no mo.
Yeah, exactly. Or they did, and you just were like, you're a woman and you don't have chest pain. It's something different, like, so we missed a lot of that. And I'm sure that was a thing for a lot of younger people with strokes as well, that just, it was missed.
I mean, we've all been on calls where it's like, based on the complaint, you're like, they're how old? Yeah, I doubt it. And then you show up and you're like, oh, foot and mouth, here we go.
Yeah, which is, I feel like it's okay to come in with some level of like, this preconceived notion of what's going on, because those factors do play into it. So, but you need to be ready to navigate into a different path when it's like, well, that 25-year-old probably isn't having a stroke, even though the call notes say it's probably a stroke, and their face is melting off and they can't speak to you. Like, oh, maybe I was wrong. Yeah. Maybe this is actually legit.
Yeah. Or maybe it wasn't. We'll talk about the mimics later.
Boom. Foreshadow. Nice. Other type of stroke. You want to talk about the other type of stroke?
So hemorrhagic strokes, 13% of all strokes, which if we do the math from 87% being ischemic, that kind of leaves us with one option. But
good
blood
math.
Vessel rupture.
Paramedic over here for sure.
Quick math.
Yeah.
But so we have blood vessels rupturing. So then we have blood that's now escaping, obviously from their intended home to the surrounding areas. So, if we think of our cranium, our skull, our head, it's built to have what it has in it. So the introduction of anything else starts putting pressure on the brain. We start having adverse reactions, with strokes being one of the common ones. And then these cerebral hemorrhages are also far more fatal comparatively.
Yeah, which makes sense, right? Like a stroke typically is self-limiting. Wherever it starts, for the most part, it's going to kind of end there. Yeah. Because that clot's lodged or whatever, and you're going to get worse to a point, but you can't get worse beyond that. Where if you're bleeding into the brain, we can start to continue to fill the cranium with extra pressure to the point that it affects the brainstem, basic functions of life, until the point where maybe you start to have brainstem herniation through the foramen magnum and the real bad stuff.
Yeah, that's a nightmare.
Yeah, it's not a good day for people when that happens.
Yeah, those are definitely progressive too, and based on the nature of our job, a lot of times when we show up and it's something like a hemorrhagic stroke, we are already just behind the 8 ball, because by the time they're truly symptomatic enough for people to call this a stroke, we're still, at most 10 minutes out.
Yeah.
And here we are.
Yeah. Before those signs and symptoms start to present a lot of the time, like it's already, the writing's on the wall sometimes because it's already progressed to that point. So,
Yep.
yeah.
So just demographics wise, people with high stress or exertion, those tend to be the people we lead into hemorrhagic strokes. Now, there's usually some sort of pre-existing weakness to the arterial wall or a condition like a Berry aneurysm. It's just some sort of brain aneurysm that's got a weak spot, right? So that's your typical space. But then the ones who have the highest risk is those with high blood pressure. And that's, time and time again, throughout our courses, throughout most medicine, you'll find high blood pressure is a problem. And it just feels like such a commonplace thing for most people that we don't think about it too much. But it's one of those like, there's serious long-term down the road effects from this. And strokes, MIs being on that list,
Yeah, for different reasons. But, the vasculature is only as strong as it is. Right. And so if we're constantly having really high blood pressures, it's stretching that vasculature to the point where you can have an aneurysm, right? Which is where those layers of a vein or artery kind of balloon out. And then you can rupture those aneurysms, right? Because it becomes so thin. It's not like there's not more tissue there. It just it gets stretched out. It's the same amount of tissue being stretched out. So it's like taking a stretchy bed sheet. Like the more you stretch it out, the thinner it gets. And it's going to be the same thing with our arteries in our brain. And there's going to be a point where all that pressure within that is going to burst through and we're going to have that hemorrhagic stroke.
Yeah. I usually describe aneurysms as like a basketball that's been popped right at the seam and you see that bladder starting to emerge out. Like there's that's your aneurysm space. Like it's a thin layer comparatively to the rest of that basketball.
Yeah.
And it's volatile for sure.
Yeah. I've seen tires do that too, where they have that big bulge.
Yeah.
Yeah, kind of the same thing. It's just the pressure bulges it out, and then you got to hope, if you need a new basketball, you need a new tire if you see one of those things. Yeah. Unfortunately, it's not that easy with the brain. Right? They can't surgically fix those, but you need to recognize it.
For sure. Yeah, that's like a shunt or, all sorts of apparatus in there.
Yeah. And then in the same vein, there are also the TIAs, or the transient ischemic strokes. And so mini strokes is another common term for these. And so those are essentially a typically minor stroke that happens, it self-resolves. So it can be up to, 24 hours by definition. And I feel like I've been on a ton of those. Those are kind of hard for us to verify sometimes because family might be like, oh yeah, their speech was really slurred and like their eye looked really droopy. And then you get there and they look totally normal, right?
Yeah.
But it's not one of those things to mess around with and be like, oh, you're a liar.
Right.
You know what I mean?
Right. I want to backtrack just a smidge too. With strokes, there's another name they'll go by. It's CVA, cerebral vascular accident or attack, depending on whatever literature you're looking at. But yeah, TIAs. I had one patient, I showed up, sure enough, stroke. I'm going to call it a duck. It looks like a duck. And then he resolved in front of the doctor. Like as we were pulling in, and he's like, oh, you're having a stroke? He's like, no, I'm fine. I have never felt stupider in that moment. Of like, I swear, man, and if you can't time them, we're going to call them strokes every time because it's not up to us to decide. Yeah,
we don't have the capability realistically, right? Like they need to have their head scanned for it to really be definitive of if it's a stroke. And especially if they're showing signs and symptoms, they need to have his head scanned to see if it's a bleed versus a clot.
Yeah.
So TIAs, really important to remember with TIAs that a lot of the time this is kind of that warning sign for the patient. So if they're having a TIA, they have all the puzzle pieces to put together to make a stroke. And this time it just fell off the table. Right. But next time, maybe that's not going to happen.
Right. About 1/3 of all people who have TIAs will have a stroke. Yeah. It's a small enough clot where it self-passes, or other reasons as well, but that's the typical one that I've seen. But yeah, they're cooking a big one for sure.
Yeah. So, if you have these patients that sounds like they self-resolve, they still need to they still need to go to the hospital. They still need to see a doctor. because long term they probably need to start making some changes, maybe get on meds for high blood pressure, that kind of thing. But it's not something for us to just to like flippantly be like, you're fine,
Right.
you know, rub some dirt in it. This is not that kind of a thing.
No, and likely they're going to, if they get seen for it, they're going to be put on some sort of blood thinner on top of it. So then there's future complications with something totally different that are potential now too.
Yeah, blood thinners, and now we have more worry for head bleeds.
Yeah,
so
perfect.
Yeah, like we were talking about earlier, medicine, there's no easy gimmies on anything. There's always a cost of everything that you're going to have.
Right.
So, whether that be medications or whatever, something's going to change somewhere else. So for signs and symptoms of strokes, we've all heard fast, and that's a real good one for us. I just saw apparently it's something you've seen before, be fast, when I was looking into this stuff. So be fast I really like. So fast is facial droop, arm drift, speech, and time. And then the BE is brain and eyes, balance and eyes. So I like that one. I think that's something that
it's a little more
widespread.
encompassing.
Yeah,
for sure.
So those are some of the things we'll see. So we'll see that facial droop. And that can be really pronounced or that can be really subtle. And I feel like this is one of those things that I don't know. I've never met most of my patients before, but if their family member's like, hey, their face looks a little off, we need to take that into account.
Right.
And this is where we're going to ask the patient to smile, tell them to show us their teeth if they don't want to, because we need to see like big cheese, right? We don't want to see like the meme of that like little wiener dog or something doing like a smirk. All right, we need like big cheese so we can really, because what we're looking for is to see if the facial muscles are working correctly. So, I would always have patients do a big smile, and I would like always have them bring their eyebrows up, bring their eyebrows down. You can make like a joke, right? Like, oh, make your eyebrows go up like you're surprised. Make your eyebrows go down like you're angry. Wow, looks just like my wife, right? Like if she happens to listen to this, we that is not at all. My wife is the coolest person. But, make it look like Sabrina won. Sabrina's laughing because Sarah's like the sweetest person who would never have to be like that. But yeah, like make a joke. It's always a good opportunity for a joke, I found.
Oh yeah.
Maybe stick your tongue out is another one when you can look for those facial muscles.
Have them puff their cheeks up. Yeah, because I've asked, there's nothing more infuriating than really trying to help someone and they just give you sass. And it's like, give me a big smile, show me all your teeth. I don't have any teeth. Okay. Will you still smile? No. Okay. Like,
help me help you.
It's so frustrating. Yeah. So you have to find your workarounds, for sure. And yeah, there's so many. Like I started doing the puff test or like the eyebrow thing for sure.
Yeah. Maybe squeeze the eyelids closed really tight. Sometimes people really struggle with that if they're having a stroke. So that's another one that you can look for.
You could even check sensation if it feels the same or not on either side.
Yeah, so lots of things that we can check for visually though as we're walking up. Look for that facial droopiness.
That's a big one.
And then the unilateral weakness obviously is a big one. So, and that doesn't necessarily mean like the left side is totally flaccid, right? It could be just some numbness or tingling. It could be a slight weakness compared to the other side. But that's another thing that we're going to be looking for. And so that's what we're doing for the arm drift.
Right. That's why you have them hold it up for, about 5 to 10 seconds to just to watch that hand. Cause sometimes it's not that dramatic. Like you're saying, it's just a nice slow over the next 10 seconds, they're falling away.
Or even like a little bit of like pronator drift where they just start to turn inwards, which if you're listening to this, if you're listening, you can't see that, but that might be something you'll see as well. Instead of arm drop, they start to turn their hand one way or the other.
Palm starts to go.
Yeah. They're not strong enough to hold that same position, which pretty much everybody should be able to do. Right. So, have them do that. As far as that unilateral weakness, I like grips and pushes too. Yeah. So put my hands out. I like to do a couple fingers, grab my fingers, give me a tight squeeze, and then have them do both at the same time and compare. And then you can get down to their feet, have them push against you, and have them pull up against you, and just see if those are similar.
Right. Yeah, and that's, I think, a disservice from all of our stroke assessments is that arm drift. Remember, the legs are also liable there. I've had, like, one of my proudest calls early on was that I identified a stroke that just came out as a fall. And all it was like, my foot just isn't working quite right. That's the one thing she said. And I was like, we're here. Let's just do it. And sure enough, she was I think it was like an 80% occlusion. So you just never know. It's a check the feet. That's where I'm trying to go with this. I'm rambling.
Yeah. I mean, this is one of those calls that if you see any signs or symptoms, let's go right now. But as you're transporting to the hospital, be very thorough. Check all those things, right? Like check the grips, check the feet, take their shoes off, have them wiggle their toes, make sure that they have all that.
Right.
You probably have the time. There's no reason not to.
Yeah. Unless you're literally 3 minutes from the hospital after transporting. And even then, half the time the hospital doesn't even care if they have vital signs. They want to know a sugar and is this positive or negative Cincinnati. Like vitals are a plus on top if you have a limited amount of time.
Yeah. So another one, actually we'll skip that. We'll talk about the cerebellar stuff later. So coming down the fast, right? We have the facial droop we talked about. We have the arm drift, and then we have the speech. And so it's important to remember we think about slurred speech, but it goes beyond just slurred speech.
Right.
So we have that slurred speech, and then sometimes it's easier just to give them something to tell you. So I like we're here in Boise, Idaho, so I would always have my patient tell me the sky is always blue in Boise, or you can't teach an old dog new tricks, something to have them repeat back to you.
Right. Yeah, I used to do the sky is always blue in Boise as well. And yeah, sometimes though, I also have a little bit of beef with slurred speech because, I mean, there's so many things that can mimic slurred speech. And one column, I still kick myself about it, but gal was intoxicated on alcohol, but no one knew she was drinking. She was secretly drinking, slurring her speech, stumbling, balance was bad, weakness on one side. I was like, oh, well, I can't be the one to say no. Turns out she was just hammered. But it's like, you just feel dumb. But you're protocol-wise covered my bases,
Well, I know one of the local 911 service, one of the medical directors in their ER, they want like a 50% over triage rate of stroke. They like that. They want EMS to be fairly aggressive with it because that's the way that people don't fall through the cracks.
Right.
So that kind of thing, if all the pieces are fitting together, you just got to do it.
Right.
It's a lot easier for them to be like, oh no, you're just intoxicated, than to be like, well, they thought you were intoxicated, but guess what? We didn't scan your head for 6 hours, and now you're too late for any treatment. So
I'd rather be wrong in front of a doctor than right and then or wrong at their house and they die in their home because I'm like, alcohol.
Yeah. And I've had multiple doctors that we dropped off, and I'm like, hey, this is pretty borderline. They're like, no, thank you. This is exactly what we want. We want you to bring these borderline ones in as a stroke.
Yeah.
So
even if it's a soft diagnosis, quote unquote.
Yeah.
Diagnosis.
Yeah. I mean, because 1 out of 10 times those soft ones are going to be really, it's going to be your foot lady, right? It's going to be a real stroke that like you maybe helped them to have a normal life afterwards that you wouldn't have otherwise.
Yeah.
So speech, we got the slurred speech, and we need to remember aphasia. That also falls under speech. So when we talk about aphasia, that breaks down into two different types of aphasia. Right. We have expressive aphasia, which is where you tell the patient to say you can't teach an old dog new tricks, and they can't speak it back to you, right? They can't form those words.
Right. But they nod along with you, like they comprehend what you're saying.
Yeah, so they're able to interpret. Their speech center is working for interpretation, but they're not able to express out.
Right.
Okay, so that's going to be expressive aphasia, and the other one is
receptive aphasia. Yeah, so that's the one where kind of inverse, right? So this time they just straight up have no idea what you're saying. You'd be like, hey, the sky's always blue in Boise, and they're going to say chicken salad. And you're going to say, okay. Different pages.
Or they'll just look at you like, I don't understand what you're saying, like you're speaking a different language.
Right. Or silence. Yeah, that's an answer too. I've had some pretty bad stroke patients who they don't say a word. And I've asked, significant others, like, are they normally pretty quiet? Like, no, they're chatterboxes. It's like, okay, then this is a red flag based on history. Yeah.
And so this doesn't we talk about aphasia, but that receptive aphasia too sometimes is visual. I don't know if it would technically be aphasia, but they might have visual issues comprehending things visually, or being able to visualize that and then express what it is. So I really like to give them a couple easy things. Hold up this, like, what is this? Oh, that's a pen. Okay, what is this? Point to my watch, right? Oh, that's a watch. Or see if they can look at something, process what it is, and give it back to me.
Yeah, I used to do something similar. What's this? It's a pen. What do you do with it? You're right. What's a watch? What do you do with it? The worst is you got to be specific too with some of this stuff, because then you'll pull out like a phone, be like, "What is this?" That's a Android 13. Like, yeah, okay, yes, paying too much attention.
Yeah, and it shouldn't be like you pull out, your Raptor shears, and what are these? Like, a multi-tool? No, actually, this is a Raptor. But you know what I mean? Like, It needs to be something that is universally known. That's why I always like the pen and the watch. Something like that. You can't pull out some weird piece of medical equipment and expect them to be like, oh, that's a hair traction splint.
Yeah. No, that's a 12 French, actually. Yeah. For sure.
Yeah. Don't you know that 20 gauges are pink, not blue? That doesn't work. So make sure it's something that's universally known, or else you're not going to get very far with it. So, and then just working down fast, we also have time. And so if there's one thing you can do that the hospital will be very happy about with these patients, it is to find the last seen normal time. Their treatments are strictly dependent on last seen normal.
Right.
And as time has gone on, they've been able to open up their windows, because it used to be like, they only had a 2-hour window to start thrombolytics and clot busting medications or whatever. And it's stretching as time goes on. They're finding they can do it later and later. But either way, that is going to be the one thing they want to hear.
Right. Yeah. I had a local, going back to, getting the sugar or bypassing vitals rather. It was a local medical director. It was like a 2-minute transport to the hospital just right there. And I was trying to prioritize getting my vitals, making sure I had everything. And she literally was like, I don't care. I want sugar and last known well. Those two things, like vital signs, I can get vitals pretty quick here, and for sure that's what they're looking for.
Yeah. Yeah. So don't forget that. Sometimes it can be very, very difficult. And sometimes the answer is like when they went to bed last night, wake up strokes or whatever. It's not up to you to determine what time that happened, if that's the case. But really do the best you can to get that information before you go flying down the highway with family left on scene that would be the ones to give you that information.
Right.
That's something that I feel like a lot of people have dropped that ball before and gotten ripped apart on.
Yeah,
so.
Doctors don't like when you're like, no, they're not a fan of that answer.
Well, yeah, because there's nobody else that can find it. We have a very distinct role in the healthcare chain, that we're the only people that see the homes or the car wrecks and all of this stuff. Nobody else gets to visualize that. And we have to be the eyes and ears for that information.
Right.
And then sometimes that conversation with families, that's up to us. Or if not, it's at least up to us in that time frame, because maybe family's going to show up at the ER 30 minutes later.
Right.
That's 30 minutes of brain tissue being lost that should have been managed because we were there and should have gotten that information.
Right. And sometimes genuinely you can't find out. They live alone. They don't know. They went to bed last night normal. What time did you go to bed? That's your best estimate. You know what I mean? Like sometimes you just got to make an educated guess.
Yeah. And just pass that along, give them what you got.
Yeah.
So trying to kind of read down the list we have here.
Work through fast. So difficulty swallowing is not a bad one. I'd say moving to the next one, decreased level of responsiveness, because there are some people who are having strokes who are very aware of what's happening. And then there's others who are just, lack of a better term, corked. They're not totally with it. Lights are on, no one's home. And one thing I think with strokes that it's not really here, but it's a consideration as a good provider, is if these people are really alert and they know what's going on, those are moments for you to embrace a human moment and put it, be a hand on a shoulder, because they're going to be scared. Put yourself in their shoes for a second. They're probably super scared, and that goes a long way. If you can keep them calm, even if the outcome sucks, they're going to remember how you treated them.
Yeah. And I'm a big proponent of being upfront with your patients too. Like I still remember I got ripped apart by a flight medic. I was in my medic internship or my medic clinicals, and I was at the ER. Flight crew comes in, and we had heard over the overcom or the intercom, whatever, right? Like CVA patient, 10 minutes arrival time, whatever it was. So I knew they were coming in. I'm a medic student. I'm trying to see all the critical patients I can, and they wheel this patient through into the ER, and I like, oh, cool. So I walk up to the medic and I was like, hey, is this a stroke patient? And he's like, how dare you? We don't want to scare the patient, like ripped into me about like, how dare you say stroke in front of the patient? And I'm like, dude, you didn't tell your patient who's being flown in a helicopter to the ER that you think they're having a stroke, right? Yeah. Like,
what a weird secret to keep.
Yeah. And for what purpose? So I feel like patients are a lot more comfortable if we're upfront and honest. Like, and I always qualify, like, I'm not a doctor, I can't tell you for sure, but I'm seeing these signs and symptoms that I find concerning for a stroke or a heart attack or whatever it is. And so I think we need to get you down to the hospital real quick.
Yeah.
And I think people will respond to that like, okay, that's scary, but this guy's going to give it to me up front and straight.
Yeah.
And, they sound like they know what they're talking about, and I'm in good hands.
Right.
I think that goes really far.
And that's just the level of trust that we get from people, like, listen, this is my job, and my job is to tell you this is what I'm seeing.
Yeah.
And there's no point in keeping secrets from your patient. Keep them in the loop, just like you'd want to know if it was your care. You know?
And if you're uncomfortable telling somebody that they're having a stroke, there's a whole lot of other things you're going to really struggle with in this job. That should be a pretty normal conversation for you of like, hey, your face is kind of droopy.
Yeah.
And sometimes sometimes you got to go really far with it. Like sometimes patients just don't want to go to the hospital, and you really need to lean into it pretty hard.
Right. They hit that sense of denial too.
Yeah, man. I had one of the most obvious strokes I've ever seen was a guy that family members showed up. And the guy dragged his foot to go over and answer the door, right? And so I think it was his son. He's called 911. We got there, and the guy's face was hitting the floor, right? And he could barely walk. We're like, hey, we think you're having a stroke. We need to get you to the hospital. I'm fine. No, I don't think so. You're literally textbook. If I could take a picture of you or video, you would your textbook stroke and just deny. Finally, after 20 minutes of us arguing with him, he finally went. But
and that's kind of a good segue actually into another sign symptom is combativeness, because there's one patient in particular. He was ended up being a hemorrhagic stroke, bilateral, 14 centimeter in diameter bleeds, and this dude he's a Marine, 70-year-old, 65-year-old dude. He's strong, and he was just fighting us. No orientation there. Even that same patient I was talking about, where it's is he a talker? Is he quiet? That guy was actively fighting us the whole time. Thankfully, one side wasn't as strong as the other, so that grip didn't hurt as bad as the other one. But
I'm gonna be on the left side of the patient.
Yeah.
You handle the right side.
That's
guys.
strategic planning. That's ALS, baby.
Yeah.
Yeah. I mean, they can get really combative just because their brain is in fight or flight. They don't know what's going on. They're just body's not working, and even if they tell it to do what they want it to, it's not working. Well,
and the issue is hypoxia. What it comes down to, right, is hypoxia, and then as the blood flow can't get to an area of the brain, and then as that area becomes hypoxic, it starts to go from aerobic metabolism to anaerobic metabolism. We start to build up lactic acid, which breaks down the cells and kills the cells, right?
Right.
So whatever part of the brain that's being affected, that part was making them combative, right? It was an emotional regulation section of the brain or something, and now they're combative. It's not them. They're not trying to be combative with you. It's just their brain is betraying them at that point. Their body is. And so, you just have to manage it the best you can. And those can be really, really hard for sure.
Yeah. Oh, for sure. And, there's still the human element of this too, of they're fighting them and you're getting angry because they're fighting you about something, but also I'm here for their really bad day, and so you got to kind of check yourself a little bit from time to time.
Yeah. I just try to always remind myself, this is not personal, right? It's the situation. It's not me. They're not trying to fight me.
Right.
Sometimes.
Right. Yeah.
Sometimes. Yeah. Especially we have a couple of friends who are providers who just everybody hates them for whatever reason, but
whatever reason. It could be anything.
Cody, we love you.
Yeah.
So working down, there's a couple things that I feel kind of fall into a not often spoken about type of stroke, and that's going to be a cerebellar stroke.
Yes.
So cerebellar strokes, and you've got a good story here in a second, but those are going to mostly present almost as a vertigo. And so it's really easy to fall into the trap of this being vertigo, because what we're going to see typically is some ataxia or some difficulty with movement, because that's what that's what the cerebellum affects. Yeah, sorry, I was getting there.
I know.
I couldn't get cerebellar out of my head, but that's what that does for our body, right? Is going to be balance, coordination, all of that, and so we can see that be affected. So balance issues, maybe some ataxia, tremors are not uncommon for cerebellar strokes. So just some new onset tremors.
Same with nausea, vomiting. It literally looks exactly like vertigo.
Yeah. And then dizziness is a big one, or dizziness or a feeling of spinning. So I remember like really good medics working under at first, and them asking patients like, does it feel like you are spinning or does it feel like the room is spinning? And I didn't really get that at first. And I think they were trying to narrow down like that exact sensation of it feels like you are spinning is maybe more of a cerebellar inner ear issue and something like that. So that dizziness or feeling of spinning is another one we might have.
Right. Yeah, I had a cerebellar stroke patient. That's, I've told you the story before, but we showed up. It was a single wide trailer. Guy was in the bathroom. Wife called, maybe a daughter who was older was there, but older gentleman. He was in the bathroom throwing up, complaining of vertigo, nausea. He's had vertigo before, all the things. And so we get him pulled out. And I get an IV, and I was like, well, I'm going to treat this like vertigo, just, follow our protocol. And my FTO at the time said, well, why don't you try a benzo? It used to be in our protocol for benzos, and I was like, or for vertigo. It's like, okay. So I called medical control, and the doctor verbatim said, yeah, that's fine. Just don't give him too much because he could be having a cerebellar stroke. And I said, cool. So I gave him a low dose. Nothing was happening. He still felt terrible. So my FTO said, why don't you just give him a little bit more match the protocol dosing. I then proceeded to bring this guy in on a non-rebreather because I worked him out so bad with this benzo. And then sure enough, he was having a cerebellar stroke. So you can imagine how thrilled that doctor was with me. Yeah, sometimes you got to just take your licks and learn what not to do, in the right situation. But I also learned a lot of good questions because even through medic school, I feel like cerebellar stroke's not something we talked about super often. But, asking younger people who are having balance problems, any vertigo patients, like, hey, recently seen a chiropractor? Because it's not uncommon for vertebral artery laceration from adjustments of the neck. Same with older folks too. Asking, have you gone and seen a chiropractor? Do they adjust your neck? Obviously make it match the scenario a little bit more. But that was because after I got yelled at by this doctor for like 10 minutes, I was like, well, now I got follow-ups. And so then he answered a lot of my questions, was really cool about it. I could see him seething, but he was at least able to make me better from it. And I learned my lesson the hard way.
Yeah. Well, I mean, that's what we're all here for. Just get better. So, I think not to say it's not that we shouldn't know this, but it's just not something we talk about. So,
right. It's kind of a weird subset of stroke, and because everyone thinks, like we even said, statistically, 87% are ischemic strokes, typically cerebral, or some variation of the big fleshy part of your brain. The cerebellum is its own unique beast down there.
Yeah. So, something else to be on the lookout if you're hearing these new onset symptoms, especially like more sudden onset symptoms of that ataxia, that dizziness, those kind of things, to be thinking down that line, right?
Right. And then you could even ask history of vertigo because that'll guide you one way or the other very quickly.
Yeah. And in general, for me, if I was kind of on the fence, like, I'm going to treat you like a stroke, even if maybe I'm thinking it's vertigo, I'm going to think you're maybe a stroke and we'll get you down there and the hospital can sort you out. Right.
Vertigo's tough just in general. Like I have one patient who was a frequent for us, just frequent vertigo, and at a certain point, it wasn't that it was like, well, I don't think this is cerebellar stroke, because I'd seen her 9 other times for the same thing. So, don't let your experiences jade you to the point you're not seeing what's in front of you, but also consider, sometimes things are how they've always been, and you just got to ask the right questions and be thorough and do due diligence.
So one other thing I want to talk about, because we talked about the Be Fast. One other thing that I think is a fairly new-ish, I don't know how, I'm old enough that new is not that new anymore, but newer in my mind, post-medic school, was the VAN assessment. Right. So this kind of falls more into the assessment than signs and symptoms, but so VAN assessment is something that's starting to hit more protocols. As far as I know, we've been on it here locally for a long time. But I think it's starting to be more prevalent throughout EMS in general of looking at the VAN assessment. And so VAN assessment is going to be assessing for large vessel occlusion. So bad strokes, right? Big bad strokes. And so VAN stands for vision, aphasia, and neglect. And so how we do it is we're doing our FAST assessment. And this doesn't work unless there's you're not even going to go down this route if there's no unilateral weakness. So you need to have that arm drift test be positive.
Right.
And if the arm drift is positive, we're going to be looking first at vision. And so we're looking for like double vision, anything like that. And then we're also looking for visual neglect. And so that would be where you take maybe like a pen or something and you hold it over here and ask your patient to, you know, like stop when you tell me when you can't see it anymore, and you go over to the side, back and forth, or, you know, maybe wiggle your finger, something like that, and make sure that they are able to see both sides, because patients having visual neglect are not going to be able to see out of one side, essentially.
Yeah, I'd stand behind them and I would say, I'm going to run my fingers on either side. Tell me when you stop or when you can see them and I'll stop. And, you know, the amount of times where it's like, all right, nailed it. And it's like, my hands are right in front of you, dude. Like, so I also would count or like do fingers, like, okay, left eye, how many fingers, and then right eye, just as a comparison, compare contrast.
Yeah, but it's not uncommon for these patients to left side, they're all good, and then right side, there's nothing because they have that visual neglect.
Right.
So we're going to be looking for vision there, and then A is going to be aphasia, which we've already talked about aphasia. So looking for that slurred speech. We're looking at, you know, those kind of things. And then N is, again, neglect, but this goes beyond just visual neglect. So this is where we are going to look to see if patients are able to mostly sensation. At least that's when I was trained on it. I don't know if you've seen something different, but mostly sensation. So the easy one for neglect is you're going to be touching both of their legs and say right, left, or both legs. And you kind of rub their legs. And if they're neglecting one side or the other, they won't feel both. And so they'll tell you just right, just left, when it should be both.
And sometimes it's obvious too when like they're if you pay attention when they're walking, like I've seen it too, where like they're bumping into stuff on one side and just unfazed keep going. One thing with neglect that I learned, another hard learned lesson with strokes, if people are neglecting one side of their body, they might not turn their head that direction. And we have the disservice of being in an ambulance, and the way our rigs were set up with the benches on their left. So if we're sitting on their left, they're looking at us, right? I've had one patient in particular, they were looking at me the whole time, talking to me. And then when I walked to the right side, they're like, where'd you go? And I realized, they're neglecting the right side so hard. I never even thought to check that they could even see anybody on that side.
Yeah.
You know, and so neglect can be, it's kind of broad, but there's ways to check for it.
Coming back to the visual side of things, we talked about it earlier, but this is also where, for the V, when you're checking visual, this is where you're going to hold up your watch or your pen too and see if they can have that visual acuity to see it and then process it and speak it back to you.
And you can even include that with your aphasia. It's kind of a 2-for-1.
And then long-term neglect, this is more just because I find it really interesting. A lot of time, patients who suffer from neglect will only shave one side of their face. Or if one of the things a hospital will do is they'll give them a circle and tell them to draw a clock on that circle, and they'll draw all the numbers on one side
that's crazy.
of the circle, or they'll only half of their plate because they just don't. Their body just doesn't. Their brain doesn't recognize, you know, the right side of whatever. So not really super relevant for us in EMS, but I was like fascinating that is a thing. I
mean, I could probably positively use only eating half of my plate, just generally speaking. So
yeah, this is America.
Upsides.
Yeah, we are overweight.
I try.
Pretty interesting things. So so those are kind of general broad signs and symptoms of stroke, but mostly these are going to be what we're going to see for ischemic strokes. Those are mostly. So how about brain bleeds? How about some hemorrhagic strokes? What are we going to see there?
Well, my experience has just been similar presentations. I've seen people with the same fast type stuff. But the big ones, it's just that comes back to one call in particular that really rattled me was that guy with the head bleed. And he was just, I was shocked at how combative he was with the whole thing. And it was that alteration of consciousness that I've seen a lot of people get real squirrely, and that was still one of the weirder ones in my head. His mental status, not so much mental status, his consciousness level and his mental status just were not corresponding well. So that's a big one on my side. I've also seen dizziness with hemorrhagic strokes, just because hypoperfusion building up.
Yeah, those are good signs. Another common one is the worst headache of your life.
Right.
That's one that you'll hear people complain about, is just ripping worst headache I've ever had suddenly. That's not uncommon for these. And then if you know Cushing's triad, we teach Cushing's triads. mostly for head injuries, but it still applies here because Cushing triad, those are just signs of increased intracranial pressure, which happens from brain bleeds as well sometimes. If they're really bad to have like, a hemispheric shift and stuff, we might see those things. So, you need to be looking for that widening pulse pressure, usually very hypertensive with a widening pulse pressure, maybe those irregular respirations and maybe some bradycardia as well.
Yeah. And I think, that kind of segues again into another good confirming sign is if you see someone looking like they have a stroke, face melting, arm falling, speech is all erratic, just because we're going to finish fast the time, it. But if you take a blood pressure and you see a skyrocketed pressure, that systolic is super high, especially if you keep that low diastolic with that wide pulse pressure there, that should almost be like there's the final nail. This is my confirming sign. This is going to be a stroke.
Yeah. I have two that I've seen. One actually will kind of beckon back to a call you were talking about, but yeah, I had one lady where, she had very slowly driven her car up a curb. It was like a residential neighborhood. She like bumped up a curb, and it was one of those ones where we got there and like PD was on scene. They're kind of like laughing. She was like a very, this was in Orange County, California. She's very Orange County, like middle-aged woman, right? Like bleach blonde hair, fake boobs, kind of, you know what I mean? Like the Real Housewives of Orange County. And so there was a bottle of alcohol in her purse. And so everyone was like, oh, it's just your typical, rich, rich whatever lady that's drinking and driving kind of a thing. And like, that was the vibe the cops were giving as we got there. And so of course that's what everybody thinks is going on. Fire was pretty whatever. And we get there and, so we moving kind of slow, the purpose of that. Right. So we get her in the back of the ambulance and I was an EMT at the time. And the fire medics down there run all the ALS stuff, right? So, but I knew the fire medic really well. And like we're loading her up and get in the back of the ambulance and it smelled like alcohol in the car for sure. But we start loading her up and I'm like, hey, do you smell alcohol? I don't smell any alcohol on her. Like, I don't like, not at all. He's like, no, I don't. That's weird. Cause we were thinking she was just a drunk lady. She was like, GCS of like 4 or 5, right? She was like super out of it. And so I pump up the blood pressure cuff. I'm checking her blood pressure. It was like 260 over whatever. And I'm like, hey, I think his name was Al. I can't remember. It's been 12 years. Blood pressure is like 260 over 80 or whatever. And he immediately like turns up to the, my partner who was driving, like, let's go now. Code 3 hospital. And halfway through she started posturing. She hands just started coming up. She had kind of like a disarabate posturing and I think she died a couple minutes after we got her to the hospital, but and it was massive spontaneous brain bleed, which it just had that hypertension and I didn't know enough at that point to be looking for like the other signs of Cushing's triads, right? Like I just wasn't, I was a new EMT, didn't know it very well. But a second one I had as a medic that similar to you were talking about, like that neglect, that visual neglect. It's not uncommon for patients with brain bleeds to have fixed gazes, right? So as the side of the brain starts to swell, they'll fix their gaze one way or the other. I think it's away. It was away from an injury towards an irritant. Okay, was how I learned it. There's no real science behind that. That's strictly observation by a lot of EMS people. Either way, they'll have a fixed gaze. And so we got a call. It was one of those early morning at the assisted living facility kind of a calls. And we get there and patient is laying on their left side, I think. And so they're laying on their left side and we're talking to the staff and they're like, yeah, he's not really responding normally, whatever. And we're doing an assessment. He's on a couch on the left side. And so we're not getting any verbal response from him. And I open up his eyelids and he's looking right at me. I'm like, okay, well, he's tracking everything when I open his eyelids. So I wasn't super concerned. And then we got him into the ambulance. And remember, he was laying on his left side, right? So I was trying to move his right arm. He was fighting with his right arm really strongly. Like, okay, everything seems good. Get him to the back of the ambulance. And I wasn't the one that moved him, so I didn't notice this until we got him back there. And my partner went to start an IV, and he's like, dude, the left side, like, there's no muscle tone. And so as he went to lift the left arm was totally flaccid. And so then we did vital signs check, and he had a heart rate of like 48. His blood pressure was sky high. He had all the signs and symptoms of Cushing's. And then when I opened his eyes again, he was still fixed to the right. So he wasn't looking at me. He was just on his left side looking fixed right. When I went to look at his eyes, it looked like he was looking at me. Same thing as you. When I went around the left side and opened his eyes, he was still looking away from me.
It's crazy. Like, and this is the stuff that as you become a more experienced provider, you can start thinking around the situation a little bit more instead of being like, poop my pants, there's a stroke in front of me, you know? And it's just little tips, tricks, and things that you could even consider using as assessment, you know?
Yeah. Yeah, that was interesting too. I asked, and this is again totally anecdotal, not National Registry question answers or anything like that, but I asked the doctor at the hospital that we dropped off. I was like, hey, so he's showing these very obvious like textbook Cushing's triad signs, and I was like, is there anything that you see is like the first thing? And he said normally from his experience, he starts to see the heart rate start to drop, and then the pressure starts to go up. Which whether that's true or not was just anecdotal, but I always thought it was interesting that
it would make sense.
Yeah. If you know the physiology of it, it kind of makes sense. But don't answer any test questions like that. But just little nugget of truth, maybe truth, nugget of
wisdom,
perception from
we'll call it that
from an ER physician. So bleeding in the brain. The hemorrhagic stroke, these are the much more lethal strokes. So be ready for that.
Right.
If you're seeing these signs and symptoms, be ready for your patient to crash on you that you might not expect so much from an ischemic stroke.
Right.
Cool.
And on that too, that's a good chance for you to rule out trauma, right? Because yes, head injuries, head bleeds, and hemorrhagic strokes can present very similarly. But if we know trauma, then that changes the whole game, right? We're going to think more head bleed, not spontaneous hemorrhagic stroke.
And at the end of the day, a lot of the time, it's 6 of one, half dozen of the other, right?
Right. Like
depending on where the bleed is within the brain, if it's a traumatic thing, it's still going to be putting pressure on the brain. It can be very, very similar. So
shifting.
That's a very good point. If you're seeing these signs, you really need to ask, are they on blood thinners? Do they have any falls? Look at their head to see if there's any decap ETLS or anything on the head that would be a sign of some sort of former injury in the recent past or anything like that.
Right.
Yeah, try to rule that out for sure. Stroke mimics. Let's talk about some stroke mimics.
Yeah, this is a scenario I love to give to my students.
You got any good ones?
As far as mimics go, like real calls.
Just in general.
I love to give stroke presentation scenario, and then they check a blood sugar that's really low, and then it's like, oh, we can maybe fix this. But if they fix it and they still have a stroke or the symptoms, maybe we have a stroke, or vice versa. As if you're a proctor listening to this, it's a good one. If you read you're reading your student a little bit, you can make it variable and maybe harder. But I enjoy doing it that way because it is something that is really overlooked, especially with how simple it is to get a blood sugar. It's also the simplest thing to overlook.
Yeah. Yeah. And that scenario you're talking about is a great example of, in class, it's usually one thing is wrong with a patient. In real life, that's not always the case. You can be having a hypoglycemic episode and a stroke.
Right.
And that happens all the time. But yeah, that's probably the number one stroke mimic. And I've never personally walked in with a stroke patient that I didn't check their blood sugar because I have heard so many paramedics horror stories about about how little they felt after they did that. And so it's been burned into my brain to not do that. But that's a huge mimic is going to be hypoglycemia that looks like a stroke. So usually before you're checking anything else on a patient showing stroke symptoms, like let's get a blood sugar ready. Let's get going with that for sure.
Right. And even if you're behind the 8 ball a little bit, and you're like, I know I got to get an IV. There's no reason to not get a sugar off your stick. Right. Like there's plenty of opportunities for you to get a blood sugar. Take advantage of them because same thing. I've never brought anyone in to my knowledge that I didn't check a sugar on. Because same thing. I've heard so many horror stories. I've seen people get yelled at for it. Yeah. And you learn your lessons really quick if you don't want to get yelled at by someone much smarter than you.
Yeah. Yeah. So that's an easy one, right? That we need to be aware of. Coming down, we got some other ones. A good one's Todd's paralysis. So Todd's paralysis is going to be patients that mimic a stroke after a seizure. According to a study I was reading earlier, prepping for this, 13% of all seizures show these signs. So it's more common, and I don't know if maybe we just don't recognize it or it resolves quicker before we recognize it. But this is something that you might see that patient has that ictal phase of the actual electrical discharge for the seizures. And then in the post phase, we might see unilateral weakness, some even like a full unilateral paralysis after. So it's going to look very similar to a stroke. And then 90% of those patients with this had clonic type seizure activity. So if you have one of those kind of tonic-clonic type seizure patients, we really need to be looking for that to see if that's something.
Right.
And the flip side of that, if we have a patient who is showing stroke symptoms, especially that unilateral weakness, try to find out if there's been any seizure activity, which maybe there wasn't even witnessed. But and again, if we have TODS paralysis, we need to treat it like a stroke.
Right.
As far as we're concerned, even if we're pretty sure it's TODS, we're still going to treat it like a stroke.
Right.
But being able to ask family or bystanders that information to pass along to the hospital is really helpful.
And that's when asking the history, like, are they known epileptics? Have they had seizures before? If they've had seizures, is TOD paralysis? Have they ever experienced paralysis of one side of their body? Like, even if they're like, oh yeah, that's every time. Oh yeah, that's every time. What if it's not this time? And it's not up to you to decide. It's outside your pay grade, my friend.
Yeah. Yeah, for sure. We kind of talked about it a little bit earlier, but subdural or epidural bleeding can also kind of look like a stroke. So either way, they need to get their head scanned, whether it's a stroke or it's some sort of, some bleeding in the different layers of the brain, whatever. They still need to get scanned. So
yeah, management's largely the same. Mostly supportive care.
At least for us.
Yeah.
Hospital obviously is vastly
totally
different. But what they need is a CT scanner, not us. So either way, we need to treat it that way. And then the last one I had here was Bell's palsy.
Yeah. Bell's palsy. That's just it's a natural, like it's a organically derived, but they just have paralysis on one side of the face. I think what's his name? Justin Bieber had Bell's palsy.
Oh, really?
I think so.
Interesting.
Yeah.
Sorry. Real quick, back to TODS paralysis. Usually self-resolves within 36 hours. Oh. So just something to know about TODS paralysis. It goes away typically within 36 hours. Yeah. I want to say that the mean was like 15 hours or something. So it will self-resolve. But yeah, Bell's palsy. Reading up on it doesn't sound like they're exactly sure what causes Bell's palsy. Right. They think it might be some sort of inflammation or something, but there's no actual conclusive evidence of what is the stem cause of it.
Right.
But it's going to be facial drooper paralysis that just really affects just the face. So you'll have that, the smile with the droop or droopy eyelids, something like that, where the hands, all that is functioning normally.
Right. And one thing I remember about Bell's palsy is that the time of resolution is variable. There are some people who live with Bell's palsies for years and years and years, and there's other people it's like maybe a week, maybe a few months. So it really just depends on the severity of whatever potential cause it is.
Yeah, like I was telling you earlier, my grandma had Bell's palsy that never resolved. She lived to be like 93. And I'm pretty sure it happened before I was even born. But I think it happened when she was like in her 30s, and the rest of her life, she wasn't much of a smiler. She's a sweet lady, but didn't smile much because she was embarrassed by it. And I'd never noticed until I was into this stuff and kind of noticed that her face looked a little droopy on one side. She would always wear sunglasses even inside to kind of hide the facial droop as well. So yeah, it can last. It can be permanent. It can last the rest of your lifetime.
Yeah.
You might also see drooling or headache. Loss of taste can happen, as well as higher sensitivity to sound on the affected side. So we just need to remember we have the facial nerves, right?
Yeah.
And so the facial nerves are affected. So it can cause other issues like the sound issues or the drooling. Or
what a crazy back and forth of you can't feel, you can't taste. Sounds are really loud though. It doesn't make any sense. But
you give and you take.
Yeah.
Yeah,
I guess.
So for our purposes, Bell's palsy versus stroke, right? Again, it's not really up to us to make that decision. So
right. Unless they have a history, I have had one patient where I was like, is your face always like that? Oh yeah, I have Bell's palsy. Oh, yeah. Okay. Well,
yeah. If it's fine. A totally a totally different call type, right? Like they're calling about I don't know, chest pain or something, and you notice that, like, ask about it. And then if they say like, oh no, it's just what my normal face looks like, man.
It's my face.
And then you can move on. But yeah, as far as like, if this is a new onset thing, another thing that's more common with Bell's palsy is it tends to be more gradual onset. So strokes are generally sudden onset, where Bell's palsy can tend to come on over time.
Interesting.
So there are things that you can use to try to differentiate between Bell's palsy and stroke, but again, it's not really our decision to make.
No.
Whether. And I've dropped off a couple patients that I was like, hey doc, I think this is probably Bell's palsy, but I'm not comfortable with just saying that. And you know, and the doctor's like, yeah, me either. Let's do the full workup and make sure. So
that's just the smartest thing to do.
Yeah, for sure. There's no reason not to, right? More in my notes, I have a couple little things. So Bell's palsy versus acute stroke, some things that can differentiate the two. Typically the age of Bell's palsy is a little bit younger. So like in the 20s, 30s, 40s is typically where we're going to see where stroke tends to be a little bit more on the older population. Like I said, onset for Bell's is usually a little bit slower. And then the upper face is always affected on Bell's palsy, whereas not always the case for ischemic stroke.
Interesting.
So, all right. So we talked about kind of signs and symptoms. We talked about some stroke mimics. Let's jump into assessment, which we more or less covered already, realistically talking about the signs and symptoms. But the big one is going to be the Cincinnati Pre-Hospital Stroke Scale, which is the FAST, right? Essentially. So that one's pretty straightforward. It's what most of us use, what most protocols are written around. There's a couple other different ones, like the Los Angeles Motor Scale is another one. I don't know it. I've never used it. I know I've seen like a printout of it. But I've never used it before.
Yeah. I mean, even most doctors' offices, like clinics that I've been in, they have some variation of Cincinnati up on the wall.
Yeah, and the ER I can never remember the name of the test. They have a super, super thorough neurological test that has cards that they'll have the patient, like all sorts of like really, it's like 250 points.
Yeah. That's something we didn't talk about is when you bring a patient in, more often than not, the doctors, when you roll into that bay and you bring them into the hospital, the doctor is going to come and do a bedside assessment real quick. And then it's not uncommon for them to roll them into a room and have a video neurologist up.
Yeah.
That's a very common thing. And they're going to run them through the third Cincinnati. So, you know, kind of touching on for your own assessments, it's okay to, I'll say, borrow other people's assessment stuff. I know you've done the same thing. Where you watch doctors and it's like, oh, that's really smart. I'm going to do that instead of this. Or maybe if this doesn't work, I'll try that. Because you just never know. It's getting around the whole I don't have teeth thing. You know, like you got to figure it out because we still need to know.
Yeah. I love to say, like, we stand on the shoulders of giants, right? Like we are not self-made. And so much of me, and I feel like I'm pretty good at my job. Being good at my job is having watched people that are really good at their job and being like, I'm going to do that too. Like, wow, that was really effective. Doing, you know, having the patient stick out their tongue and wiggle it, like that makes a lot of sense. We're checking cranial nerves. I'm going to start doing that too. Or, you know, all those things. So yeah, definitely steal everything as far as assessment tools.
Yeah. As far as knowledge goes.
Yes. Yeah. Yeah. We're not condoning stealing other stuff.
No.
But yeah, steal all of those. You're not stealing, right? Like, but put that in your toolbox. If you're an EMT listening to this right now, your toolbox is probably really small. And maybe this is adding to your toolbox, right? And learn from us, learn from everybody. And maybe you'll try something out and you're like, that sucks. Why did they do that? And throw it away. But after a couple of years, your toolbox should be pretty stellar for your style of medicine.
Right. If you steal something from me and you say it sucks, I want to talk to you after. We'll have words.
Yeah, we'll drop Wade's contact maybe.
Drop the at.
So yeah, as far as assessment wise, right, we're talking about the FAST and then maybe the VAN assessment. And then beyond that, it's just your typical stuff, right? Do your secondary, ask for differential diagnoses, right? Like check the blood sugars, ask any alcohol, any drug use, those kind of things, right? Do a good neuro check.
Yeah. I can't rule out trauma to remember, like if the left foot stops working and they fall down, we might have a couple of compounding problems to deal with.
Yeah.
So secondary in medical, oftentimes it's overlooked and it's very kind of in my opinion, it's kind of like specific to certain calls and situations. But remember, real life's not as isolated as school. So you're going to have I was walking and my left foot stopped working, so I fell and now I hit my face on the concrete. And situations will change.
Yeah, always delve deep, right? Like you've got 20 minutes with a patient, you should be asking questions for 18 of those 20, right? You should be constantly asking questions.
Yep.
And if you run out of questions, start at the head, work your way down, and just ask questions about
and
stuff.
Sometimes you can ask the same question again. Like, hey, real quick, just confirming, like, I know the answer. This is buying me 5 seconds to think, and if that's all you need. But make sure you're listening, not just thinking of the next question you're going to ask.
Yeah, for sure. Yeah, you need to hear those pieces to put them together. Treatment-wise for stroke, very minimal for us, right? Like, go fast to the hospital and realistically, the biggest treatment that we can do as EMS providers is go to the appropriate facility. That's the best thing we can do.
Yeah. Don't go to a standalone ER where they're going to need to be admitted. They could maybe help stabilize and they might have a CT scanner, but the longevity care is not there.
Yeah. Even locally where we have good, good larger hospitals, if we have VAN positive patients, they want specific hospitals because they have the capability. Because now, I mean, they'll go beyond just thrombolytics. They will go and they will suck clots out. Like they'll go like I can't think of the term of the procedure, but they'll enter in like they're doing like a cardiac catheterization, and they'll go up to the brain and they'll pull clots out. But that's a high level thing that not all hospitals have.
Yeah, interventional radiology.
Thank you.
IR.
Yes. So make sure you know your protocols, make sure you know your hospital systems. That's probably the best thing we can do for the patients is get them where they need to go in a quick manner, because you don't want to go to the wrong hospital and be like, hey, actually, they should be over there.
Yeah.
And then have to take them over there.
Would you say you got to remember to be fast?
That would have been, you should have waited. That's where we should have signed off. You blew it.
I'll come again.
But yeah, so make sure you come to the right hospital. And then like minimize scene time is huge too, right? Time is brain. So these are the patients for me personally. If I walk up and they got that face melting going on or whatever, and I can recognize a stroke instantly, I don't care about your blood pressure right now. I don't care about any of that right now.
Right.
Where's my gurney at? Let's go. Like, let's just get you on the gurney. We can get everything else en route. Let's get started down the road. So we're not losing brain time.
Yep, exactly.
And then beyond that, if there's anything corrective that you could treat, like blood sugars, treat blood sugars. We're not going to go into IV sugar or anything like that because that's its own topic of like where do you manage that blood sugar range for these patients. But yeah, if there's something that you need to treat like that, go ahead and treat that. If you have the capability, do an IV, maybe multiple IVs. They like 18 gauges or larger because to push contrast dye, they need an 18 gauge. So that's typically the reason. And they actually really prefer ACs for the contrast dye.
I had one nurse, it was a radiology nurse. I was like, hey, just for my knowledge, our protocols say, 2 large bore IVs. And she exact words were, no, as many large bore IVs as you can get. So I've literally put 3 IVs in one person before. Perfect. And I was like, this feels like such overkill. And then I saw them later, just coming back from a call, and just sure enough, all of them were being used. So yeah, get as many as you can, large bore.
Yeah. And then go fast to the hospital.
Yeah, be fast.
There you go.
Felt right.
Good. Yeah. Anything else you want to add about strokes?
Nah. Yeah. Try to hone your craft, be good at these, because they are something you're going to see quite a bit. And there's always going to be uncomfortable, but find your comfort in, okay, I know these things. I know what I'm looking for, and I have several routes to get my answer. If you have that in your toolbox, you're going to be just fine.
Yeah, this is the most uncritical critical call you'll probably run.
Yeah.
But that recognition is really important. So
life-changing.
Perfect timing to have to cough.
Yeah.
Cool. Well, that's all we got. Thanks for being here. Hit subscribe, all that stuff, and we'll see you guys next time.